So just to say that, as Jeter said, I am one of the pediatricians working in a district general hospital. And I am going to be talking about some of the comments that were relayed to me by my colleagues in various district general hospitals. And my colleagues include anesthetists, pediatricians, nurses, and other healthcare providers who have been involved in either transfer or stabilization of a sick child prior to transfer. So obviously I did receive feedback. Some of these were corridor conversations which were given to me personally face to face, and some of these were by emails. But I would like to assure you that I have responses from various district general hospitals. I do understand that this YouTube live broadcast is being viewed by people from across the world, and certainly some of the things that are discussed right now might be in keeping with what happens within their area, and some things might be quite alien. So Northern Ireland is a tiny, tiny, tiny country, but they have their own issues which may be unique to us. But either way, just wanted to start with thanking you all for giving us the opportunity. So my plan really is to highlight the positive comments, and might I just add to say that there were overwhelming number of positive comments and responses from my colleagues thanking the PICU team, the retrieval team for all the effort, the support, and the expertise that has been offered through the years. And I want that to be the main take-home message, although it does seem like one point there. And then I tried to thematize some of the responses and the questions that were put forward, and sort of some of them maybe logistical and not particularly educational and might want to be addressed at a different sort of setting. But these were the themes. One was the NISTAR availability, which can be a difficult topic to discuss within this conference. The second point was using a single point of contact or coordination or video conferencing facilities where necessary. And I remember Rory pointing out how this would be beneficial. I wanted to plug in the Telelink meetings, which we as a district general team member feel that is a really incredible educational opportunity, and just how grateful we are that they can continue. Wanted to highlight some of the queries around the challenges of time-critical transfers, and I know there were previous sessions which outlined the challenges, but just wanted to bring our perspective through here as well. There were a lot of questions and comments made about the borderline sick, the ones that are not quite intubated, but sick enough that potentially would fit PICU, but the thresholds differ. The borderline age, which is 14 to 16, which is a thorny subject again, and about the unwell, unintubated children. So just saying which children would be, which we would think would be more appropriate for PICU, but PICU wouldn't. So there was just a few wee comments on those. Also some discussion about seizures and questions about those. And I know Shauna covered beautifully some of the key issues that were highlighted. High flow nasal oxygen and its ever pervasive uses, which have been expanding through the years as well. So just a few comments on that. And then the last point was made by one of the other colleagues in another district general hospital about receiving feedback from PICU, positive feedback. So these are the sort of main areas to cover. So if you want to move on to the next slide. So just again, wanted to highlight the very positive comments that were made by a number of my colleagues. My anesthetic colleagues in different district general hospitals are incredibly grateful for when the transport service is available, and even when it's not available, to have a conversation about suitability of various induction agents and the process of difficult airway management. So wanted to highlight that. One of my colleagues in a district general hospital highlighted an opportunity when she was awaiting the retrieval team with the view to get the patient across, but as it turned out, things changed, and the transport team were very helpful and supportive in helping with withdrawal of acute intervention and reassigning to palliation. Another comment made was they're always at the end of the phone to provide advice if asked. The kid that doesn't need transferred yet, the kid that is potentially sicker or trickier than usual, and an invaluable resource of a source of help, support in these invariably stressful scenarios. So just wanted to bring in somebody from the expert panel here just to say, in terms of the patient who was initially intended to come into PICU, but then was reassigned to palliation, is that something that you would land up doing reasonably often, or it's a rare event? I don't know who wishes to answer that. Maybe Chris wants to answer that, or
Yeah, no, happy to. It's quite a rare thing, Shilpa. Palliation in the district general hospital is something that is probably the right thing for the child. I think moving them to the intensive care unit sometimes gives the parents false hope that something can be done. And actually, if the district general need help, the retrieval team coming out and helping with that in the DGH is probably the right thing for that child and their family. It feels probably quite uncomfortable for the district general to do something like that they're not used to. And that is something that we're very happy to support with. As a transport team, we have a set of skills that's in that area, and we do unfortunately look after a number of children in the end of life care, and we have expertise in that area. So we're very happy to share that. So it's definitely something we can be involved in. It would be quite a rare situation, though. What we normally find is the district generals aren't happy at all to entertain that, and would quite often come and move the children to ICU to do that there. But certainly, and it sounds like that was probably the right thing in that situation. Did it work out well for?
Yeah. So the feedback was really positive in that specific situation. I haven't experienced it, but certainly there was significant support and reflection that was very positive. Thank you.
There certainly has been other situations where I've certainly been asked to go out and put a line in a child for palliative reasons, and we've gone out and we've done that, and that's meant the child could get a trial of treatment in their local hospital without being moved to a new team that's not so familiar with them, and again that has worked well too. So we're more than happy to help out with those situations.
Thank you. So then moving on to the other questions then, Tudor, if you could go on to the next slide, please. So as I pointed out, the very first one was NICE-STAR availability. And obviously we understand that, we're all under a lot of pressure, and in a district general hospital, there are curveballs thrown our way at all times, coming from the emergency department or from the acute ward, the postnatal ward, the delivery suite, or the neonatal intensive care. Some units have bigger intensive cares than other units. So it is a packed area with lots of different areas to cover. And certainly a sick child is obviously sucks in a lot of time and energy and effort and resources. And therefore, not having the NICE-STAR team adds another layer of complexity. Certainly in the bank holidays and weekends, etc., where the cover is patchy anyway. And also there were some comments made about if there isn't availability, is there any private outsourcing that is available? So maybe this is not the right forum for it, but Chris, I'll let you comment.
Yeah, so the first thing I want to say, Shilpa, thank you very much for collecting all these really valuable questions and comments. You shared the presentation with me beforehand, so I can see you've an awful lot in it, and really interesting questions from a lot of people in Northern Ireland. The difficulty is we're not the right forum to answer these questions in. Some of us work for NICE-STAR, others don't. They work from transport teams around the world, and we've also people who don't work in transport teams, and we have no authority here to answer on behalf of NICE-STAR, particularly in a public forum as well. We're also an international conference where we have an international audience, and the individual policies of a transport team in one area aren't going to be interesting to probably 95% of the people viewing along today. What I have done is I've spoken to our transport lead, and we think these questions are important, and we're very happy to answer them at our Telelink meeting, which thankfully you've mentioned. So we'll get you answers to those questions, but I don't think this is the forum to do it. And I think we probably should stick to general questions about management of critically ill children that will be relevant to most of our audience watching today, but we will get you answers.
Thank you. That's brilliant. So we can move on to the next one then. The other comment that was made, and this is just italicized because I am phrasing it exactly as it was. So the sort of key area was to have a single point of contact where a phone is picked up, information is taken, coordination is done, and then we are informed and supported accordingly rather than making a number of calls. Oh, sorry, that just, okay. So one of the comments was, I would like a one-stop shop where we, oh, sorry, just disappeared there, where we could liaise with NISTAR specialist general pediatricians in RBHSC rather than contacting them separately. But there is a single point of access. That was one comment. And another comment on the similar theme was just a reflection from one of the consultants that in one of our SAIs, the PICU consultant had mentioned the service of single point referral center for retrieval. This central point could receive the call, arrange appropriate levels of retrieval, keeping the DGH updated, and provide different ways, say, for example, an MDT discussion with a PICU consultant or a relevant specialist. And he also said that this service is well established in England, and I'm not sure why it's not happening in Northern Ireland, but worth exploring the views of the PICU consultants. So these were the two sort of comments that I picked out from the lot. So maybe get your comments on that. And is that something that is happening on the ground?
Yeah, so you've really described the gold standard of the way transport should work, Shilpa. And having worked across in England, this is how it happens. You phone into a single centre, there's a call handler, takes your call, and then they are bringing the relevant people in. So you're not having to chase, for example, a PICU consultant round. You're not having to chase up a bed. If we need a neurosurgeon, they're brought into the call. So you're describing the gold standard of the way a retrieval team should work. And it takes the pressure off the person making the referral. They're getting all the people in one call, the bed agreed. And like I say, it's the gold standard. And it'd be interesting to hear what the other retrieval consultants here, do they work in a similar system?
I think, Chris, it depends on what your local system is in terms of, if you're commissioned for critical care transport, then you're doing critical care transport. Therefore, the phone call comes to me as the intensivist. I accept or decline the patient, and the retrieval consultant goes out on the call as required. If it's not, so general pediatricians are not involved in that conversation, because if it's a critical care transfer, I would accept them to a critical care unit, and I would do whatever critical care medicine is needed, and then I will link in with whatever discharge pathway is appropriate for that patient. It's not a discussion. If the patient is going to a ward under a specialist team rather than PICU, it is not by definition a critical care transfer. So I will not be getting involved in that conversation. Everybody's pretty busy. You need to pick who your people are rather than bringing everybody in as a one-stop shop if it's not entirely appropriate. So it comes down to what your transport service is actually commissioned for. Is your transport service commissioned for critical care transfers, or is it commissioned to do all transfers? And that's the crucial question.
So it does exist for adult trauma services. So they do a call and send model, where if they arrive in the A&E department, they're critically unwell, the onus is to get them to the major trauma centre, which is the Royal Victoria Hospital. And all the ED does is pick up a phone, say we're transporting this patient and moving them as quickly as possible, and that's it. And it's up to the receiving unit to do essentially what you're saying: organise the specialties, get a bed secure, and the whole emphasis is to get the sick patient to the area they need to be. For paediatrics, that does not exist, because when they came to commission the major trauma centre, paediatrics didn't really feature in it. So I assume it's all about money, like everything else, unfortunately.
And I just wanted to plug in at this point the PICU Telelink meetings. And I really want to thank Lindsay, Mark, etc., for giving us the dates out in advance, which helps us plan our team. And we have local champions. So I don't know what's happening within other trusts, but certainly in Craigavon, we have an anesthetic lead for PICU, sort of telelink leadership, and a general pediatrician. And we also have a trainee champion. So I suppose the work is distributed, and also it's very helpful to have the cases identified. But I was just wondering whether this could be even further formalized, have some admin backup, create learning summaries, and maintain a repository of this learning, because this is such an incredible opportunity to meet in relatively real time, because it is happening on a monthly basis, and also lay out an annual calendar, understanding that of course it's really busy and things might have to be cancelled, as a lot of meetings do get cancelled, especially when things are really busy. But I just wondered if there has, and I suppose we can discuss that at our next week's Telelink meeting, but just in terms of even further formalizing the process, is there anything in the pipeline about it?
Yeah, I think this is probably best discussed at the local meeting, but good points.
Okay. Thank you. So then we can move on. So one of the consultants and I suppose that this is kind of a comment that involved more than one person, but I've chosen this particular one because I thought the point was well made. So the time critical concept needs to be explored, as I feel that NISTAR team should be able to mobilize themselves as soon as possible and give us an indication of time of arrival to a district general hospital. Sometimes organizing a DGH team and ambulance to do this transfer can take longer if the NISTAR team could be there within, say, an hour to most DGHs. And I suppose, Derry and Earn might take a bit longer. But I know Rory raised this point there, and he did mention that, yes, sometimes, NISTAR could do it, but I don't know if you want to make any further comments on that, Rory, or anybody else, because that was one of the comments raised.
Yeah, I think this should probably be the exception rather than the rule. It's not a complete no to NISTAR considering doing the odd time critical transfer if there's mounting factors against the DGH being able to do it in a timely manner. The difficulty is a time critical transfer. There's obviously something that's critical in it, for example, a child's brain that needs to get to a neurosurgeon. And the fastest way of getting that child to that definitive care is the priority. And it's not who comes and does it. Generally, coming out to a not a child that doesn't need time critical intervention, a retrieval team has been shown to get better outcomes for the child. I think if a retrieval team was coming out to a child who needs time critical transfer, you're likely to get worse outcomes, and that's the reason we ask you guys to do these transfers. I understand there's logistical problems at times. We have the same. We're not sitting in an office ready to go at out of hours. The transport consultants quite often at home at night time, and they'll be making their way in. There'll be preparation of kits and preparing things before they go out. You'll have the journey to a DGH. The average handover and packaging of that patient, even with a quick and there's nothing to do, takes about half an hour. So you're probably talking at least an extra hour of preparation on both sides, journey for that person to come in, the extra journey to the patient. So even if things in the DGH are taking a little bit of time, they still should be able to get the patient to definitive care much quicker than that. And one major bit of advice I was given about time critical transfers, and Rory mentioned it in his talk, is call the ambulance as your first thing that you do. And there's some really good practical advice in Rory's talk about how to get the right ambulance. If you have the paramedic standing at the bottom of the bed, you're not going to put central lines in, you're not going to put art lines in, you're not going to go and do anything unnecessary. That is a reminder to you to get out the door and get that patient to the care they need. So, like I say, for 99.9% of patients, the district general hospital should be doing them because we are just too slow. We're not an emergency resuscitation team, and you guys are the best people to move these patients. doing simulations in your own department, working as how you can speed these up in terms of getting out the door is probably the key thing, rather than us coming and taking over and doing these ones. Obviously, like you say, there will be that odd one where we might be the best people to come and help. There's a delay. We're actually ready to go, and we could get there quick enough to do it quicker than what you could, and that would be the right thing for us to do that then. But they're going to be incredibly rare that we will be able to do that.
Yeah,
I would back that up, Chris. I kind of feel like, and this might come across a little bit harsh, but sometimes PICU is the backstop of when beds are tight, who's going to be able to look after these patients. When the wards don't feel comfortable, they go to PICU. You know, the buck stops with ICU a lot of the time, particularly from a nursing point of view, because of how highly skilled the nurses are. So they're used around the hospital to plug gaps, which is difficult from an ICU resource point of view. Time critical transfers exist across the world, across the UK, certainly. And in those circumstances, it is recognised that the local team should be doing them because it should be faster. If it is not, or if it's felt not to be faster, the answer to that is not to get somebody else to do it for you. The answer is to review and evaluate your own service and create the improvements that you need to make your service efficient and better. The buck cannot stop with another team, and that is a problem that ICU face in so many regards. So I would bounce that one back and say we cannot pick up the flag for something that should be done, commissioned and led by yourselves, because you are perfectly capable. And the job that district general hospitals do is phenomenal. And they are fully capable of doing it, and they do it exceptionally well.
Yeah, I think the biggest delay is the paramedics getting the ambulance out. So I think there's some really good practical advice in Rory's talk. I imagine, for example, the ambulance might be called, when you're ready for it, rather than when you recognize it's time critical, or, for example, there's some maybe confusion over what type of ambulance you're looking for and the contact number. So I think definitely, if that is your time limiting factor, working with your local ambulances and trying to find out how they want to be notified about time critical transfers and trying to get that time down is probably the best way to speed up those transfers.
that makes a lot of sense. Thank you.
I imagine some part of the difficulties is even within the time critical period, there is different variations, and that's, I've seen extradurals who are time critical who can sit there for 4 hours, be absolutely fine. I've seen an extradural sit there for 15 minutes and cone, and the same with block shunts. And you have block shunts that someone will watch overnight, there's block shunts that deteriorate really quickly. So if the feeling is that they're stable for a while, the transportation can come and get them, but you don't know what they will do. They're all individuals, so I think that's part of the difficulty, that in time critical there is still variations.
Even within the UK, there's huge variations from region to region, because each region is geographically different. So London is small distances, lots of ICUs. They can get from A to B generally faster. If you work in the northwest, they cover North Wales. There's 32 hospitals, 8 million population. The furthest away point is 3 hours on the road. Scotland is even more challenging. So it needs to be region specific, I would say. So I think London, it's probably easier for the retrieval teams to be there physically and move them in a way that doesn't affect transport time. So if a child needs neurosurgery, it wouldn't probably affect how long it takes for the child to be in theatre. Whereas if you're in a DGH that's an hour and a half, 2 hours away from where the retrieval team is based, you're talking about 2.5 to 3 hours at least before they even get there, plus handover, plus going back. The outcome is going to be much worse if it's an acute surgical problem, whether this is neurosurgical or general surgical, which is generally most of the time criticals anyway. So it needs to be region specific. There's no one size fits all. Scotland is different to London, and so on.
I think you have to be careful as well as a district general team when you're maybe in resus or something, and there's this false impression that we'll ring to get a team, and everyone stands around and maybe people walk off, whereas you have to bring the team together and say, right, we are the transfer team, and we're mobilizing this patient in such and such a time unless told otherwise.
Well, thank you. Lots of comments to take home. There were a few sort of specific situations of 14 to 16-year-olds which were mentioned in terms of feedback. Now, this might be very specific. This refers to 3 cases. There were 2 cases of pneumonia in a smaller district general hospital, ages between 14 and 16, who required high flow but not intubation. And it was felt that the smaller district general hospital, it would be difficult to manage them within that setting. And then another 15-year-old with a neuroleptic malignant syndrome following a medication with a very high CK with further elevation in subsequent blood tests. And the specific consultant said that the difficulty we have in this setting is that some adult ICU consultants won't answer the phone to us if the child is under 16, and PICU won't take any unintubated children. Now, I'm not sure about the latter comment, whether that is necessarily true, but whether it was only in this instance. So maybe if somebody wants to comment about that, and then the next one is a separate issue. So maybe.
Yeah, so I think with that one, we do take unintubated children. The difficulty with a lot of these cases is getting the unintubated child to PICU. So there's a lot of kids who need extra support in the district general hospital, and that's the right thing to do for them. Although sometimes the district generals are unhappy with doing that support, but or they don't have the ability to do it. And the difficulty with that is the only alternative to move those children safely is to put a tube in and move them to ICU, which is not in their best interest. If some high flow in the district general could turn them around. I think a lot of it is, again, maybe Northern Ireland Pacific in terms of the ages. The issue you have is there's different ages for paediatric patients in district generals compared to the tertiary centre, and there's obviously a group in the middle that overlap, and I think that's potentially region specific. But the other issue of the transport is there's a lot of asthmatics, for example, that we're referred. They're sick, but the only way we can put them in the back of an ambulance is to intubate them, and they're not quite sick enough for that yet. And sometimes the DGH is going slightly outside their comfort zone is the right thing for that patient, and maybe putting high flow in a slightly older patient and turning them round is the best thing for that specific patient. So it's not always that ICU won't come and take the patient or won't transfer them. There's a good reason behind us not coming out, and the fact that we have no way to move this patient. They're in that middle zone where we just have to wait and see what they do. And the thing is, a large number of them will get better. And if you look at asthma as a major example, if you intubate an asthmatic, as I'm sure Gail's going to tell us later on today, there's a very high risk that you're going to kill them by intubating them. And trying to avoid that at all costs is what we're doing. So some of that may have been lost in translation, but there's often a reason why we can't come and move certain patients.
Just to say, there's also probably regional variation as to whether centres have HDU sort of units specifically. I know in Belfast we don't with PICU or kind of there's the wards in district general or children's. Other centres will have specific HDU beds where you may be able to move patients who don't maybe need PICU care, but maybe need often from a nursing ratio more than anything else, need that extra bit of attention. So that also feeds into the regional variation.
And of course, if the patient does need ICU and they are 14 to 16, you would take them in PICU, isn't it?
Yeah, and PICU, and I know this is slightly still regional, but we're happy to deviate to that. We take up to 16 in terms of age. Sometimes we will take older patients who haven't been transitioned over to adult care. So, occasionally we will have an older patient who is still under a consultant in the hospital and hasn't been transitioned. But as a general rule, we take up to 16.
Thank you.
Yeah, we would do the same. Sometimes we would ask, sometimes our adult ICU, if we're pushed for beds, would take an adolescent if they have got an adult based problem, if it's a drug related problem or something like that, they would take those patients. I do think we need to debunk some of the fear about high flow oxygen, to be honest, because we were doing that in Antrim when I was ST1, which was now a number of years ago that I will not care to mention. And for some reason, the fear of doing that in a district general actually seems to have grown over the years rather than dissipated. And it's a very safe therapy. And I don't consider it to be a critical care therapy. I consider it to be humidified oxygen. And I don't think we should be pushing to move these patients away from their families, away from, where it's local to home, just because they're on high flow and they tick that box, which the threshold to put that on is entirely, subjective on many occasions. If they deteriorate to the point where they need critical care intervention, as Chris says, absolutely, you go ahead and you do that. But I think from an education point of view of how to look after these patients on the ward, that's probably the thing that will make the biggest difference. Take the pressure off your transport service, take the pressure off your ICU bed so they can be used for actual critical care patients, keep families closer to home, better patient-centered care. I think that's the way forward.
True. We'll probably leave the last comment then for Gail's talk later on, because I think she'll cover that. So if you want to move on to the next one. So again, this was covered earlier on by Shauna, so it might be answered already, but colleagues in the District General Hospital still have quite significant reservations about trying to extubate a patient that they've intubated for seizures. So Shauna, having that guidance that you had put up there is very helpful. The correct patient identification, correct patient selection for extubation would be useful, although I can just highlight the reservations. It's quite a valid reservation there, like who will make the decision. The pediatricians must stay, it'll block a theatre. Is this really feasible? So I just wanted to highlight this comment, but I don't know if you want to add something to it.
It might be worth actually mentioning what happens to these patients when they come to the ICU. So in general, when a seizure patient comes to ICU, we stop their sedation, we wake them up and we extubate them, and they're ready to come back to you within an hour or 2 hours. The difficulty of bringing them to ICU just to extubate them is probably not the right thing when you look at that patient's journey as a whole, because the parents are worried they're going to ICU, and actually you're using up valuable resources of a transport team, particularly over the winter. There may be other children waiting. And the difficulty is, I would almost argue with you that actually keeping this child asleep until the transport team arrive and then get them packaged up and out, you could probably have had them extubated before the team have arrived. I go into theatre occasionally and there's a child trying to climb out of the bed and propofol is being injected in to keep them asleep. And that is not a child who needs to be kept intubated to move to the ICU to be extubated. I think Sean hit the nail on the head with the guideline. There's specific patients we should be doing this in. There's specific patients that we shouldn't be doing this in, and that's probably we need a regional guideline before we start moving on this. But it is something that we think actually would have probably less time recovering this patient than waiting for ICU to come out and retrieve them.
There needs to be a culture change, Shilpa. So we 10. So I'm talking about the Northwest experience. So when Newt started about just over 10 years ago, no one was doing this in the DGHs, and after 10 years of a lot of education, outreach, trying it out, we have a nearly 75% extubation rate of our fitters in DGHs, and everyone is singing from the same hymn sheet, and people are comfortable, with the exception of a specific population of patients. So, if the CT is abnormal, the trauma cases, we don't push for extubation. Babies under 6 months, which are higher chance for, NAI or encephalitic processes, they're the ones that tend to not extubate. The rest, provided you don't give morphine, you don't give any more midaz for ongoing sedation, and just having them on propofol and then switching it off if they tend to extubate. So it's a culture change that's needed, more education, but it's definitely feasible to achieve in any region. It's not good for the patients to move them 2 hours away where they don't have the social network to support them, only for them to go back the next day. It's just not good use of resources. It's not good for the patient. But I feel the anxiety because it's change, isn't it? It's changed from what we have always done, and it's more work for DGHs who are inundated already. So it's not easy, but it's definitely feasible.
Well, thank you. That was very good insights, and certainly hoping that culture changes. And then we go on to, I think there's only 1 or 2 more questions. I think this bit has already been answered a couple of times. I certainly, my personal experience with high flow is really positive, but again, it is about the patient selection. So maybe just a quick note about who you would feel is not suitable for high flow within the setting of what we have.
Yeah, I think it's the child in extremis or who's obviously heading there. It's picking your patients, as you say. There's a patient that you think you can recover with high flow, by all means, give it a go. And we save intubating lots of children using non-invasive support. If there's a child who very obviously is well over that hill and is rapidly deteriorating, putting them on high flow just delays the intubation. And that's probably what the person at the bottom was describing. It's using it early to prevent the child getting this sick, rather than using it when intubation is inevitable. Although if intubation is inevitable, it might buy you a bit of stability while you're getting the anaesthetist round and getting the child prepared and moved to theatre.
Thank you. I think the last bit then, this was just a comment made by one of our DGH colleagues to say it would be nice for PICU colleagues to send back compliments and acknowledgements. I certainly have received positive comments, but I just wanted to highlight this, maybe just in terms of positive feedback, and it potentially could happen at the PICU Telelink meetings, but even otherwise. I remember there used to be a certain consultant who used to send letters just to sort of send a thank you for your positive input, and I thought that was very helpful. But I don't know if you want to say or comment about this, Chris.
Yeah, I think it's a brilliant idea, Shilpa, and it's something we probably should do more of. It's funny, Damien Gates was telling me a story recently. He spoke earlier on, and he actually does this quite a bit. He had actually phoned a midwife up who had spotted a sick baby recently and gave them feedback, and that meant the world to them. And he got lots of letters, emails back from that department thanking him for what he did. So spending some time and a few words of thanks for somebody who's done a great job really does help. And you're right, it's something we should do more of.
I just want to come into this. So my comment has got nothing to do with the transport, but just about a change in practice. So if you're trying to get a culture change, I think giving that positive feedback gives the team an idea that they're doing well. So my example is we do a lot of reductions in our emergency department of fractures. We started it off our own bat, but soon fracture clinics started emailing us to say thanks for what we had done. Good reduction on this patient. Thank you. And makes a huge difference to how you feel about continuing on with that action. So I do think, Shilpa, that is a great thing to do, and I think the team can adopt that, or should adopt that, because that positive feedback is going to instill that change within the DGHs as well.
And certainly within the setting of critically ill patients, that, because we're obviously on the edge for it, and certainly would reflect a lot on a situation like that, and receiving compliment would help that reflection, obviously. And
what's the system, Shilpa, for the reciprocity of that? Does the PICU get letters to say thanks for taking the patient and things like that as well? Or is there, because I just, I would expect when I arrive to pick up a patient, I would already be saying thanks, great job, you've done really well and all the rest of it. And like I would expect most transport teams to be pretty complimentary of the district general for getting the patient as far as they have without even needing to be formal about it. That's just common courtesy, isn't it? Because they've done such a good job, right?
Yeah, Peter, I can only talk about my own self, and yes, absolutely. I mean, it is a real sigh of relief to see the transport team. I can't thank them enough, and certainly do. Yes, and the ambulance crew get their teas and coffees and little feet up moments as well. But yes, absolutely. I think it's a reciprocal thing,
Yeah, I think sometimes we worry about formalizing just being nice and appreciative of each other, and actually that should just be every day.
Yeah, absolutely. Agree. I think that's, and then just before we go there, I just wanted to show the last slide, which has some acknowledgements. So this is not the exhaustive list of people who gave me their comments, but these are the list of people who were happy enough for their names to come up and the acknowledgements. So I just wanted to acknowledge all of them. And then you can go back to the QR code, Tudor. Thank you. And that's me.